topic which is little, I think, more theoretical, because still we have not used this modality, how to measure the microcirculation, but let's see what all is available and what all we can be done with through it. A case example, we all see in our routine practice, a 55-year female having angina, baseline ECG, TMT positive, but when we do her angiogram, it is normal. And we label it as non-cardiac chest pain. We say, no, it is some obesity, just because BMI is high, and we ask her to consult the physicians. So are we missing anything? Let us look over the microcirculation. So my presentation would be about the anatomy, the indices which we can measure, how to measure, what is the clinical relevance, and what is the real-world scenario. So we all know that coronary anatomy, like all FFR, IFR, whatever the indices we are doing, we are just looking at the conduit vessels, which constitutes about the 5% of the microcirculation of the coronaries. The remaining pre-arterioles, arterioles, capillaries, which constitute about 90% of this, we are not addressing them. We assuming that, okay, microvascular resistance is okay. But these are the patients which we are treating with them, but we are largely ignored and not diagnosed or treated in these cases. So what is the determinants of coronary microcirculation? How is this coronary blood flow regulation? Let us go back to a physiology lab. We always say when physiology Guyton was there was auto-regulation in the cardiac coronary arteries. Whenever there is increased demand, the patient coronary perfusion pressure increases, there is increased flow. Whenever there is metabolic control, lactates increases, there is increased flow. Endothelial function, when you find that, okay, there is increased NO, there will be increased dilatation. And neurohormonal regulation and shared stress. This all in an exertion, it causes increased flow. But does it happen in a real world? We know in this, with age, there is some microvascular dysfunction which happens at the level of your arterioles or prearterioles. It can be a structural remodeling, like in cases they will have a wall-to-lumen ratio, there is hypertrophy, or it can be a functional remodeling, that means there is a vasodilatory response is decreased. Suppose in a patient of HFpEF or hypertension, aortic stenosis, you have intimal thickening, or patients with having an impaired vasodilatory response. So this is a normal resting in hyperemia, but if structurally it is a thickened artery, your flow will not increase, but the epicardial arteries would be normal. So can we assess these microvascular dysfunction in a lab? So let us be aware with few terms which is important in these cases. First is absolute coronary blood flow, coronary flow reserve, IMR, index of microcirculatory reserve, hyperemic microvascular resistance, and microvascular resistance reserve. I know FFR, IFR is routine clinical practice, but these terms we never use it because it is not available to us. So if we see the coronary microcirculation, the mostly thing is about, if the absolute coronary blood flow depends on two things. One is pressure gradient, we call PD by PA and CVP, and the microvascular resistance, which we do not address in these cases. So how can we assess these microvascular resistance? So there are many formulas which have been done, various guide wire-based measurements or thermodilution method, and how to assess this. So method is just what we use in our cardiac output assessment. If you remember the cardiac output assessment thermodilution method, we put a Swan-Ganz catheter, give us a line, see the temperature difference, and calculate the blood flow or the cardiac output. The same thing which follow in these cases is thermodilution method. The wire of Coventus, which is coming, it's coronary wire with temperature and pressure sensor. This will basically assess, we give 3 ml of saline or boluses, see the temperature difference, and calculate the transit time or the blood flow in these cases. The second modality which can be done by Doppler method, which is still in the research purpose, which tells about the peak flow velocity rather telling the temperature difference in these cases. So how to calculate in these cases? This is basically your thermodilution method. You give 3 ml bolus of saline at room temperature. You see the temperature difference, how much time it is taking for transiting from your normal temperature to getting a lower temperature. And by this thermodilution, you calculate the flow, which is equal to 1 divided by the transit time. That how, if it's a time is, suppose you're getting more time, that means it's having a more coronary blood flow in these cases. And this is labeled as a CFR. So coronary flow reserve is basically defined as what is the flow at rest and what is the flow at hyperemia, or hyperemia is usually induced by adenosine in these cases, and the value which we mentioned is more than 2 to 2.5. But there is limitation because CFR addresses both epicardial vessels and microvasculature, so cannot differentiate between microvasculature. And CFR is basically dependent on the baseline coronary blood flow. If a patient is in a hyperdynamic situation, then CFR won't be a very good indicator to these cases. So we need to see the resistance. Can we see the microvascular resistance? As an FFR principle, the same principle is applicable to here, this Ohm's law. We see the pressure gradient and the flow across it. But again, how to see the flow in these cases. So there are two terminology, that is index of microcirculatory resistance and hyperemic microvascular resistance. Both are measured by the same, a thermodilution method or a Doppler method. And rather seeing this, they say, okay, we see the pressure and we see the transit time. If the transit time is more, we know the resistance would be more. And if the transit time is less, we know the resistance would be less. So the value which is considered to be less than 25 is a normal value, and HMR is 2 to 2.5. So same principle, we give 3 ml saline, 3 bolus, so in a resting and hyperemia phase, see the pressure difference and see the transit time. And if the transit time is more, we know that we are using with the microvascular resistance. But again, this has some fallacy because we are using at a particular one point. So we cannot calculate we are just taking the transit time. Again, it's having some coronary blood flow involvement. So can we calculate the absolute coronary blood flow in these cases? A technology of continuous thermodilution method in which you have a sensor, same wire, give a continuous infusion rather giving a saline, and with continuous infusion, you calculate what is the blood flow by calculating the temperature difference between the two and seeing the transit time in these cases. And this gives the exact coronary blood flow. What is in normal LAD, it's 50 to 100 ml, and whenever there is hyperemia, it increases about 3 to 4 times. It will go to 175 to 350 ml per minute. And we can calculate the microvascular resistance reserve in these cases. What about the vasoreactivity? Vasoreactivity is that basically whenever the patient exercises, usually arterioles should dilate. But there is sometimes a kind of vasoconstriction due to endothelial dysfunction. So adenosine, we all know it's an endothelial independent vasoreactivity, but acetylcholine is an endothelial dependent vasoreactivity. So if there is any endothelial dysfunction, there will be a vasoconstriction rather than a vasodilatation. So there are 3-4 responses which happens in a normal response. Whenever you acetylcholine, there is vasodilatation or less than 20% vasoconstriction. But in cases of microvascular spasm, there will be ECG changes symptoms, but there will be no epicardial pain. Whereas in endothelial dysfunction, you will have a more than 20% epicardial narrowing, and spasm, we know it's more than 90% of narrowing at acetylcholine. Why we are talking about this? Why this much discussion about it? Because we know that INOCA is an entity which we are addressing in these patients for long. And this is basically, we have to see that INOCA is due to microvascular dysfunction and due to vasospastic angina. So we have to differentiate, and the treatment modality will depend, because if it's a vasospastic angina, you will try to not to give a beta blocker, you will try to give CCBs and nitrate in this. And if we see, CMD is not a new entity. I think we remember our MBBS days. This was first time reported in 1967 when they evaluated 15 premenopausal females, which found that abnormal stress test but normal epicardial arteries, and they labeled as a neurocirculatory asthenia or a syndrome X. But they mentioned one line: it is the microcirculation myocardial cell which has led to this. Maybe in 97 they came up with a group statement, but again it didn't work. Never go ahead with it. Why did it take so much time? One, acceptance of disease entity. We say, okay, let it label syndrome X, let us forget it. There was lack of direct measurements of these. And third and most important, safety and concerns and time consuming. Because if we see acetylcholine, we all know the VT-VF is negligible, but it's still there. So, but now we have to come out with this. It cannot be in the black box. Why? Because if you see the magnitude of the problem, the 70%, about 50 to 70% have angina without obstruction. And if we see our real world scenario, this was a retrospective analysis we did from our institute. 10,000 females evaluated from 2005 to 19. 34% have a normal or mild disease, and they were labeled as a non-cardiac or a non-ischemic. So this was the study which we published from our institute. So diagnosing microvascular angina, what the guidelines says, if the patient is coming, it's a class 1B. But still, the measurement to go for CFR or IMR in these cases, it's class 2A, and acetylcholine is class B because of your increased risk. So if you see the take-home message, microcircular assessment, there are various indices, and maybe in future, by coming of a new technology, we would be able to see that. It is a real, measurable, and often missed. It represents both structural and functional abnormality in microcirculation. It is increasing as common cause of chest pain. And it's associated with poor outcome because the data has shown, despite having normal coronaries, these patients have poor mortality. And we have to find endotype identification so we can do a targeted therapy. Thank you.
I think excellent talk, Dr. Roopali. So I think it's a really, really big and open topic because nobody's really sure. And we're learning as we go along. If anybody has a quick comment, otherwise we'll move to the next talk.
I have a small question. So, are there any reliable non-invasive ways of measuring microvascular dystrophy?
See, there are non-invasive ways. I didn't cover that because of time shortage. Like echo, we say Doppler velocity, but we all know in real clinical practice, it's very difficult to get a good Doppler velocity. Then there are modalities of PET, SPECT, and cardiac MRI. Now, cardiac MRI, the issue is the availability. We all know, me being a premier institute, we still don't have a myocardial blood flow calculation by cardiac MRI. So in general population, I cannot say who will get it. PET and SPECT, they have that ischemia, but if you have a negative PET, that doesn't rule out it's not INOCA or non-cardiac chest pain. So still we are in maybe a dark, maybe we need, the little tunnel is there, we'll be coming up with CFR or something, we might give a better, otherwise in our study if we see, we usually prescribe them anti-anginals and they respond to it. So we are doing it, but non-invasive, yeah, I think there are methods there.
Even QFR is coming up with, even QFR is now used for the diagnosis of CMT. So it is, we are going to get a value as soon as we do an angiogram.
Fantastic. Thank you so much.